Scope of endodontics is, first you should know the different pulp and periradicular diseases. What are all the reversible, irreversible, everything pulpitis, and you should be able to differentiate between them. That means you should know the differential diagnosis. What is the difference between all the diseases? Then only you will be able to evaluate it perfectly. And other scope is the vital pulp therapy. Before proceeding to the root canal treatment, you should always do the minimal invasive procedures which prevents the root canal, such as pulp capping, that is nothing but the covering of the pulp with a material which will regenerate the dentin, and pulpotomy, that is only the partial removal of the pulp. So first you should try with these vital pulp therapies. Only if they don't succeed, then only you will proceed for the RCT, that is the root canal treatment, which removes the vital pulp. Next, the non-surgical treatment of the root canal system without the periradicular pathosis. So first you should select selective surgical removal of the pathological tissues, and if any tooth is avulsed, like if the tooth comes out, then you should do the intentional reimplantation, and if requires you should remove a tooth structure such as root end resection, not all the tooth structure, only some root part, and you should be able to do the filling from back aspect, that is the retrograde. Retro is nothing but from backwards. And if if at all is required, you should be able to hemisection, like half the tooth you will remove and half you will keep. And bicuspidation, that means you split the cusp of a tooth into two parts and you will give two separate crowns for that. And endodontic implants, the bleaching of discolor, these are all the treatment modalities that are available in our endodontics. So implants, endodontic implants, bleaching of the discolored dentin, and retreatment of already done RCT, and treatment procedure which is related to the coronal restoration, like the means of post and core. Like in conservative, for the extensive tooth removal, you have amalgam pins. Similarly, in endodontics, for the tooth that is grossly decayed, you will do root canal, followed by you will place a screw in the root structure, which is nothing but the post and core. And if any extraoral pain comes, such as swelling and any pain which is related to ears and all, that also should be able to diagnose. And traumatic injuries of all types, like Ellis class 1, Ellis class 2, Ellis class 3, everything you should be able to identify. And you should also cover any pathological tissue biopsy, and you should be able to differentiate between the tooth pain and maxillary sinus pain. So pathogenesis of endodontic diseases, these are nothing but pulp and periapical diseases, which we will see in next class. So what are all the etiologies of endodontic diseases? How come endodontic diseases occur? So it can be either due to the physical agents like the heat generated during your cavity preparation. Otherwise, it might be due to the chemical agents such as the cements which you place. The acidic pH of the cements may leach into the dentinal tubules, and it can cause you the pathogenicity. And first in 1894, W.D. Miller, he identified the bacteria in the deceased pulp. And also, these physical and chemical factors may induce the periradicular inflammation. You require a large body of scientific evidence that, apart from these physical and chemical factors, you require an endodontic infection. That is, the infection caused by bacteria is required for the progression of pulp and periradicular diseases. So the infections may develop in root canals which are devoid of the host defenses. So infections may develop either as a consequence of pulp necrosis or might be due to the pulp removal during the treatment. So what are the infection? Bacteria are the major microorganisms. In advanced stages, bacteria, they colonize and they together form the biofilms which can be adhered to the canal walls and which plays a main role in the infection of the tooth structure. So when these bacteria encounter our host defensive system, the inflammatory changes may take place in the periradicular and the pulpal tissues. And if the infection and the inflammation takes place in the periradicular tissue, that is around the apex, you will get the apical periodontitis, that is the inflammation of the periodontium. When the infection or inflammation takes place in the pulpal tissue, you will get the chronic irreversible pulpitis, that is the irreversible condition of the pulp which requires the root canal treatment. So the roots of root canal infections, it may be either from the accessory canals that are present, it may be might from the apical foramina, and it might be from the dentinal tubules. So under normal conditions, the pulp and dentin complex will be very sterile and it is isolated from all the oral microorganisms which are present in the enamel, that is in the crown part, and the cementum, that is in the root part. But when the integrity of these natural layers, those are enamel and cementum, is breached, like any damage or any break in the enamel and cementum occurs, then the pulp dentin complex will be exposed to the oral bacteria and then the microorganisms which are present in these caries lesions will be bathing the exposed area. As a result of the plaque or calculus may form on the exposed area. So the routes from which the microorganisms can travel to the dental pulp are. So from the root side, we have seen those are lateral canals, apical foramina, and the dentinal tubules. Whereas from the upper side, you can see from the caries exposure, the microorganisms may enter the pulp. Due to the tooth fracture, the microorganisms may enter the pulp, or due to the iatrogenic exposure, that is during your cavity preparation, the microorganisms may enter the pulp. So the other routes includes, as we told, apical foramina, accessory canals, and ankylosis and dentinal tubules. So these microbes from the subgingival biofilms, they might be also associated with periodontal disease. They have access to the pulp via all these channels that we discussed before. So these bacteria in the caries process, they are non-motile, like they can't move, but they invade the dentin by the repeated cell division, which pushes them into the dentinal tubules. And these bacterial cells may also be forced into the tubules, due to which they develop some hydrostatic pressure on the dentin. So what is ankylosis? It is a Greek word which means refugee, and it's also called convocation. So it is a process by which the microbes, they may be transported. Microbes which are present in the blood and the lymph, like your general body microbes, they can be transported to an area of inflammation in the pulp and the periradicular tissues, as a result of which the tooth may develop pulpitis or periradicularitis. So Sculler in 1880, he was the first one to study the concept of this ankylosis. Later, Richard also tried few cases, and he found out from where the extraoral sites the bacteria are reaching the body. And other few scientists also demonstrated the movement of this systemic bacteria, like they all highlighted the concept of this ankylosis. So the process of ankylosis has been specially associated with bacteriemia. Bacteriemia is nothing but presence of bacteria in the blood, and infective endocarditis, that is the heart disease. So once the dental pulp becomes necrotic, the root canal system may becomes a sanctuary, like bird sanctuary type, for clusters of bacteria, their byproducts, and their degradation products of both the microbes and the pulpal tissues. So this ankylosis concept will explain the clinical situations. That is, you won't diagnose or you won't detect any bacterial contamination of the pulp and periradicular tissues. Like they won't be present in the tooth structure area, but at the inflammatory process will be seen. Why? Because they might be present somewhere outside the tooth structure, and due to the concept of this ankylosis, they are spreading infection into the tooth part. So it is the mechanism through which the traumatized tooth with intact crowns will become infected. So this idiopathic post-operative, after your cavity preparation or anything, if it happens, this post-operative idiopathic, means unknown origin pulpitis, is also known as ankylotic pulpitis. Why? Because it is spreading due to the concept of ankylosis. So this E.C. Rosno, he introduced this concept of elective localization. So next you have two important theories, that is focal infection theory and focus infection theory. So what is focal and what is focus? Focus is nothing but a distant body site. So you have a specific body site other than the oral cavity in your body, that is the focus part. From this focus part, the bacteria and the bacterial byproducts, they spread into all the parts where they will give you the focal infection. Example, the microorganisms from an infected oral site, that is from the focus of infection, they might spontaneously or after due to some idiopathic dental procedure, they again enter into the blood circulation and they cause the disease, which is nothing but the focal infection. So this example is, you have extracted a diseased tooth, which is nothing but the focus of infection. From here, due to the traumatic extraction, the microorganisms and their byproducts are spreading towards the knee joints and all, and they cause you inflammation of the knee joints, which is nothing but arthritis. So what you will do is, you will identify this diseased tooth and you will remove the tooth. So the infection, that is the focus, is removed. So the spread of infection, that is the focal infection, the arthritis can be cured. So to cause the focal disease, like to cause a disseminated spread of the bacteria, they must travel from this focus, that is the center part, to a distant body site. So how they will travel? They will travel through the bloodstream. So while traveling, they cause the bacteremia, that is the presence of bacteria in the blood. So examples of these cases are acute apical abscess and during the treatment of the infected root canal or your periradicular surgeries. So it is being shown that bacteremia occurs, that is the bacterial presence in the blood will happen if the root canal procedures are performed beyond the apical foramina. So if you perform the over instrumentation of your RCT, the apical foramina will get stimulated. That is the inflammation of the apical foramina will happen. That is the focus of infection. From there, the microorganisms will travel and they will cause you the bacteremia, that is the focal infection. So this is the inflammation of dental pulp. So you have dental caries, from there the microorganisms are coming and they are necrotic the pulp, and they are also causing the inflammation of the pulp. These are the few dentin proteins that are present in or around the dentin, and these are the periapical lesion that is happening because of the entry of microorganisms from the crown part. And you have macrophages, osteoblasts, and all the cells of inflammation that are present in this area. So the inflammation, as you all know, it is the local physiological reaction of the body to the noxious stimuli or irritants. So the objective of inflammation, the stimuli can be either traumatic or chemical or bacterial. So the objective of inflammation is it should remove the irritant and it should repair the damaged tissue that was damaged due to the irritant. So the symptoms of inflammation, as we all know, rubor, tumor, choler, dolor, and loss of function, that is functional osteo. All these are the 5 cardinal signs of the inflammation. So rubor, choler, tumor, dolor, loss of function. So the inflammatory response of the connective tissue, like how the tissue will respond, how much the inflammatory tissue will respond, it will vary because of the surroundings. So the why? Because the pulp, which is enclosed in hard tissues like enamel and dentin, it has a limited portals of entry. So it has no efficient collateral circulation. So the inflamed pulp, only pain and disturbance of function are recognized clinically. You can't see all the macrophages, leukocytes, WBC, everything that are present in your second year pathology. Cells of inflammation only we can't picture. Why? Because the pulp is an enclosed space and it is protected by enamel and dentin. So only the pressure and the infection, inflamed pulp and pain can be seen. So inflammation, as we all know, it can be acute, that is a short-lived, and chronic, which is of longer duration. Whereas the histological picture, you can see in acute inflammation, polymorphonucleocytes will dominate, whereas in the chronic inflammation, lymphocytes, plasmacytes, monocytes, and macrophages will predominate. So the vascular changes, you know, as it includes diapedesis, arteriovenous blood pressure movement around the blood vessels, this all happens in the vascular changes. So the first one, fundamental vascular changes are vasodilatation, that is the dilatation of the arterioles, and the second one is the increased capillary permeability. So this leads to a series of interrelated physiological and morphological changes. So vasodilatation will open the dormant capillaries, which leads to the increased blood supply to the affected area and which will rise the intravascular pressure, blood flow, and permeability of the capillaries. So the proteolytic enzymes that are released from the injured cells and bacteriological toxins and traumatic mechanical forces, they may release histamine from the mass. So the histamine that is released will increase the permeability of the venules by contracting the endothelial cells that are present in the lining of the blood vessels, which will form the gaps. From these gaps, the fluid will leak out from the vessels into the tissues. So the tissues will be accumulated with the fluids that leads to edema.